Okay, here is our last unit for the class. It's on newborn and the care of newborns. So I'm going to just go over the main things. You will see in your ATI there is some things on how to take care of preterm babies, large for gestational age babies, and babies with respiratory distress syndrome. I'm not going to go into that because it isn't really covered in your NCLEX, and if you are not going into this field of nursing, these are things that you won't need to know for maternal newborn nursing. So I'm trying to not overload you with information that's not really something that's important for you for this class. But in your ATI, they do have those resources. It's the very last part of the ATI book, and it's all about newborns. If you're interested in NICU nursing, nursery nursing, postpartum nursing, all labor nursing, any of those, you will want to learn specific things about caring for newborns. So I encourage you to do that on your own. When I first was hired as a NICU nurse, I went through didactic. It was a 6-week didactic course. Every Tuesday we would get together. This was at New Mexico Children's Hospital, and we were taught by the neonatologists and the neonatal nurse practitioners all about specific things on the care of newborns and especially preterm babies. So that is an education that is beyond nursing school, I believe, and it's very specific and highly specialized NICU. So if you're interested in those kinds of things, get a job as a NICU nurse, and hopefully you'll get really good education. If not, contact me, and I have lots of things that I could offer you as far as education, really great books and things like that that you could learn from independently. And I highly encourage that if you're interested in being a NICU nurse, is to really kind of learn things for yourself and get your RNC and things like that. But that's all about this class. So let's carry on. So newborn nursing, we're going to talk about this neonatal period. This is the time of period of transition to extrauterine life. So we've talked about when a baby is delivered, they have this time where their vasculature is changing. So during in utero, when they're growing in utero, they do not need to breathe. They do not need to gain oxygen from their lungs. So there are different pathways and routes and vessels that are open that really just let them bypass the lungs. One of them is the ductus arteriosus, which is the most common one that has a hard time closing. We call it a PDA, a patent ductus arteriosus. And if you see that, that can lead to lots of problems with their oxygenation needs. But most babies transition just fine on their own, and a transition nurse team will, depending on how high risk this delivery is, either one person or a team will transition this baby. And they're going to do certain things right from the start to assess this baby and to see what kind of needs they need at this transition period. So neonatal time period, just to define things, is immediately following birth and up to the 28th day of life. So if you're interested in neonatal nursing or want to learn how to transition babies or just want to learn about the vasculature that happens between the fetal circulation and the newborn circulation, it's an amazing thing that happens when that cord is cut and the baby takes that first breath. Just lots of things happen. So these are links to videos, and you'll be able to just click on them for yourself. They're Khan Academy videos, and it explains fetal circulation, and then it explains what changes after the baby is born. So I'm not going to go over it in class. Maybe I'll post them. I'll post them in the module so you guys have access to them if you want. So the first thing we do is we want to take an APGAR. And while we're transitioning babies, we're taking APGARs at the same time. We're going to look at different parts to see how well that baby is transitioning. So different things to see how well that baby is transitioning. So the first thing we're going to look at is respirations. That's the number one important thing that we look at in babies, is how well they're oxygenating themselves. If we see a baby crying, great. If he's not crying as much as he should be, we're going to make him cry. We're going to stimulate. We're going to rub his back. We're going to dry him very vigorously with towels, not only to get him dry, so that thermoregulation, which is the second most important thing when a baby is transitioning and being born, we're going to get them to cry, because the more they cry, the more they expel the fluid from their lungs. We're going to look to see at their reflexes. We're going to make sure their reflex irritability, So that just kind of means that if we are bugging this baby should be irritated. A normal term baby will be irritated by you touching him and you messing with him. A preterm baby and a baby that is sick will kind of lie there very flaccid, will not be as motivated to cry and be irritated by what you're doing to him. We're going to look at the pulse. We can either do that by auscultating with a stethoscope, or we can feel the umbilical cord and we can measure the pulse. The pulse is really important because it takes a minute for them to kind of get to a normal, which is, remember, 110 to 160. If they're anywhere above 100, then we know that they're doing okay. If not, then we need to give oxygen, or maybe, even more severe things, which is what the neonatal resuscitation program is all about. And it's an algorithm that we use. So we're going to look at the skin color. Skin color tells us a lot about the perfusion of that baby, right? And we're going to look at the muscle tone to see how well they are doing neurologically, if they're sick or something like that. So we look at their appearance, pulse, grimace, activity, respirations. That's what APGAR stands for. And we are going to either give them a 0, 1, or 2, and then we're going to add them all up. And the results that we get are going to tell us some things. So we're going to take it at 1 minute and then 5 minutes. If they're still down, meaning if they have a low APGAR score at 5 minutes, we're going to take a 10-minute APGAR score too, because these are records that are going to go into that baby's hospital stay records. And it's going to be used at the pediatrician's office. It can be used for a lot of things. So if there happens to be, so my son was diagnosed with autism when he was about 2.5, and they asked me about his APGAR scores to see if maybe his brain took a hit or something like that. So APGAR scores are important for that permanent record. So if a baby gets 0 to 3, then that baby is in severe distress. We're going to give that baby oxygen, most likely CPAP, which is, we're going to occlude the airway and actually force the air in so we know that the air is in there. If it's a really small baby and we know that it's going to happen anyway, they'll probably, and these are the respiratory therapists, they, in their scope of practice, they can intubate at delivery. So if there's not a neonatal nurse practitioner or a neonatologist around, the respiratory therapist will intubate that baby. 4 to 6, they're going to have some difficulty, so we're going to have to stay with them and watch them because they're having a hard time transitioning. And then 7 to 10, we know that they're going to be able to transition well on their own, and we're going to have to give minimal support at the transition time. So we're going to look at these vital signs. I need to fix this. It's not 120, it's 160. Clinically, in the clinical setting, we used to use 120, but now it's all being changed to 110. That's just evidence-based practice. They do research, and then it changes. And this is one of the things that's changed over the last few years, is 110 instead of 120. So 30 to 60 is respiration. That's normal respiration. If a baby is breathing faster than 60, the reason why that's important is because we're not going to feed that baby. There's too much of a high risk for aspiration. So we're not going to feed any baby with a respiratory rate above 60 or nipple them. We can gavage them, but we're not going to nipple them. And then blood pressure, we don't really take blood pressures unless this baby's in the NICU. Blood pressures are more for NICU babies, which was really hard for me to get used to when I started working postpartum, that we weren't giving, or transitioning babies, that we weren't taking blood pressures on every baby. And then temperature, a really easy way I was trained, and I think it's just easy to remember, is 36.5 to 37.5 is the Celsius. And that's the easiest way to remember, hard to forget. So we're going to look at all these things. We're going to take these vital signs very often. Our hospital has us do every 30 minutes. Your textbook says every 15 minutes. Really, it's just like the postpartum mom. So you do it very often, at least every 30 minutes in that first 2 hours of transition. And then if they're stable and they have good vital signs, it'll be less and less. At 24 hours of life, we will do it just Q shift. So every shift we will be able to take their vital signs. That's kind of what I just said. So we're going to look at the umbilical cord, and that's important because if there is one big old vein and 2 arteries, then that is a normal umbilical cord. Question, and I think we did talk about this a little bit in lab for some lab groups, which of these vessels carries oxygen to the baby? Remember, this is the umbilical cord coming from the mom and the placenta. So the answer is this big old juicy vein. A lot of people try to define arteries and veins by saying that arteries always carry oxygen and veins always carry deoxygenated blood. And the real answer is that arteries always leave the heart, veins always come back to the heart. So the umbilical cord is, this umbilical vein right here is going towards that baby's heart. That's why it is an umbilical vein, and that's why it carries oxygen. So, first thing, like I said, we're going to look at is respiratory rate. This baby looks like it's doing okay. You see a little acrocyanosis, which is where they're perfusing their core central organs, and they're going to, worry about their extremities later. This is a normal finding, acrocyanosis. So, like I said, 30 to 60 breaths per minute. Babies are irregular breathers. So, you will hear them breathe, 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 and then they'll take a long pause. And then breathe, 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 and then pause. And that's just normal for them. But also something to consider is that they're obligatory nose breathers. So, if they have anything in their nose, you will need to remove it with this bulb section right here, because they will not breathe without it. And what babies do when they can't breathe, or when they're stressed, they just stop breathing and they turn blue. And so you need to give them oxygen. So we need to make sure that their nose is cleared. Remember, we always suction their mouth first, then their nose when we're suctioning, so we don't aspirate. Sorry, I just said that opposite. We're going to suction their nose first, then their mouth, because we don't want to stimulate them to aspirate whatever could be in their mouth. There we go. Just went over that. So let's talk about this adaptation in the respiratory system. So it has a lot to do with surfactant. So term babies should be producing enough surfactant. We talked about that earlier when we were talking about the amniocentesis. So if they do not create enough surfactant, what happens is every time they expirate or exhale, they're going to suffer from atelectasis, which is the complete closing down of those alveoli. So what happens is we give them surfactant. Surfactant is a tension reducer. So it's kind of like dish soap. So if we give it to them, you and I will keep this little end pressure. This is what PEEP is. If you guys know anything about, you guys have worked with ventilators, that's what PEEP is. PEEP is end pressure. And we all maintain some end pressure in our alveoli when we exhale. And what that does is it makes the work of breathing less hard. Babies that have atelectasis have to work every time to pop those alveoli open, which is why you hear grunting. When babies are grunting, they are forcing that air into the alveoli and opening those closed alveoli. So we have to, if they don't produce enough surfactant, we do what's called vent and surf. So we're going to vent them just for minutes, just with an ET tube, and we're going to give them surfactant. Even if they're not going to stay vented, we vent, give them surfactant, which is a spray, down their ET tube, and then it reduces that work of breathing. So, with a vaginal birth, this is the other thing to think about with respiratory problems. With a vaginal birth, that compression through the vaginal canal compresses their thorax and forces fluid out of their lungs. Babies who are born via C-section do not get that thoracic compression. So that's why in C-sections they do that incision small as they can, because they're going to artificially try to create that thoracic compression. They don't do as good a job, and C-section babies are spitty babies because they're losing that fluid slowly over time. Okay, I'm going to pause here because I'm running out of my 15-minute time. So I will come back in just a minute and finish this slide.